So, cancer is something that doesn't affect people just locally here in North America. It's something that affects the world. It's not isolated to just one continent. It's isolated by lifestyle. I've talked before about the prospective urban-rural epidemiology study, which was published in Lancet Journal in 2019, that showed that in high-income countries and even in high-income high middle-income countries, cancer was the number one cause of mortality in adults, and it exceeded the rate of mortality in adults of cardiovascular disease by a rate of 2.5 to 1. So this is a global crisis. I'm not going to say pandemic because that's a word that's been driven into the ground. But this is a crisis of global proportion. And you'll see this on the list of people that are joining us here. Not just Europe, not just Asia, but also North and South America. And of course, many of our colleagues from Canada, Sarah from Canada, Quebec, but it's cold up there. And because it's not here. So let's go ahead and get started. Always wanted to kind of give an opportunity in these webinars to just open up the floor to Q&A. Questions. We've had a lot of questions submitted ahead of time. So what I did is I pulled a bunch of these questions, a lot of great questions, a lot of crossover in those questions. And I wanted to try to tackle quite a number of them and then leave the door open for some questions in this session. So one question I saw repeatedly is, what is integrative oncology? And I think that's a good question, good basic question to start from. Conventional oncology is approaching cancer from a war perspective. It's when you look at full dose chemo, when you look at surgery, both of these strategies for the conventional cancer approach, they were both born out of war. Surgery was born out of, treating trauma on the battlefield. Chemotherapy was born out of World War II. It actually had its origins in World War I with the Chemist War, as it was called. But that is what then led to full-dose chemo in the 50s and 60s, working initially with Sloan Kettering. The four pillars of conventional are surgery, chemo, radiation, and then what they say today is modern-day immunotherapeutics. But understand, integrative oncology is working to integrate strategies that don't just target the tumor for destruction, as a result destroy the body. They actually integrate with the body's functions. And so what that means is we're going to dually target the tumor for elimination, but what we're also going to do is we're also going to target the immune system for support. So when you look at full dose chemo, it destroys the immune system. That's one of the reasons why you see cancer spread. Yeah, so we got plenty of questions ahead of time, but I encourage you to leave questions now. So I think we got that fixed. So when you look at integration, it's recognizing that from a conventional standpoint, this definitely can kill cancer cells. But when you go to war on the cancer itself, you go to war de facto on the body. So it's integration of the original context and historical of the root word meaning of integrative, which is actually heal or restore. And so it's working to restore the body, not just destroy the tumor. Because if we destroy the tumor and yet eliminate the immune system, we have defeated the whole purpose of what integrative means in Latin integrationem, which is to restore, renew, or remake. We want to integrate spirit, mind, body. When you look at cancer, it's not just the physical. That is a very important part of this. But when you look at the spirit and the mind, many people with cancer, there is major trauma, major stressors in their life that have contributed to the process of cancer or are inhibiting, in fact, the process of healing. We want to integrate, as I mentioned, the dual and simultaneous objective of eliminating the tumor, but yet supporting the healing of the body. Here particularly, we're talking about the immune system because that's what gets destroyed with conventional cancer care. We want to integrate therapies. But the integration of therapies, so this could be the integration of nutrition with supplements, nutrition with repurposed medications, repurposed medication with IV therapies. It's about integrating or stacking, as I like to call it, precise stacking for providing the right treatment for the right patient at the right time and the right combination. It's about the integration of allopathic and holistic therapies. One of the problems that we have in medicine today, I am a conventionally trained MD, but I'm also an MD homeopath, so I have the ability to understand both sides of the fences. What happens in a lot of oncology today is the two sides just yell insults at each other, and the people that suffer the most are the patients. So when you look at conventional cancer care, if you're, as I tell patients all the time when they come in our clinic, if you walk outside and break a hip, I'm not going to tell you to take more vitamin D. You need surgical correction there. Likewise, we don't want to give radiation. We would rather avoid surgery. But if somebody has a tumor in the brain and that tumor is creating edema, and that edema has the risk of herniating the brain, that could be life-threatening immediately. We must provide a therapeutic intervention to then be able to provide a holistic healing strategy. So sometimes where there is a life-threatening event, we will bring in a rare use of the conventional, but use that and integrate that together. And that's what really provides a true integrative strategy, one that maximizes effects but limits the negative effects. We want to integrate with the body. The more we can work with the body, perfect example here is the immune system, the less we have to worry about destruction and try to rebuild it. It's really interesting when you look at the immune system as it relates to chemotherapy. CD4, many of the immune cells are wiped out by full dose chemo, but some of them recover. And a lot of literature says that the CD4 helper T cells, there's questions about whether they ever fully recover. And CD4 helper cells are T cells that are attacked by, for example, HIV. And that shows how important those cells are to the function of the immune system, because it created massive immune dysfunction in patients with AIDS. Full dose chemo can come in and create a very similar problem with those same T lymphocytes, and that can lead to a ongoing, maybe never recovering immune dysfunction that then can lead to recurrence, can lead to metastasis, and then potentially lead to new cancers. We want to integrate the science, and this is the one thing that always surprises doctors when I talk to them, is the science behind natural, holistic, and integrative strategies. The problem is when you look at it from a continuing medical education standpoint and conventional oncology standpoint, they don't get into the natural, holistic, and integrative strategies. Perfect example, I had a question from a reporter this morning talking about vitamin D. The current recommendations are that there's no need to check vitamin D. And my question to her was, if you go to your doctor for high blood pressure, does the doctor check your blood pressure? Well, her statement was, of course they do. I said, well, then what dose? And then how do you determine if that dose is appropriate? Well, they give me a therapy, I come back and they recheck my blood pressure. I said, exactly. That's the same process. And Linus Pauling talked about this. It's a process of understanding pharmacokinetics and pharmacodynamics. When we look at natural, holistic, and integrative strategies, we do not ignore scientific principles, nor do we ignore pharmacologic principles. Linus Pauling said we do when we talk about vitamins, but when it comes with medicine, all of that applies, but it applies to natural therapies as well. So we follow the science. We don't want to dictate the science, we just want to follow it. And if that means we use integrative, we use integrative. If that means we use holistic, we use holistic. That means if we use natural, we use natural, but we're going to do so by the science. And we'll get into some of the science as it relates to some of these questions in a second. And the last is the integration of precision therapies. So it's not just the integration of therapies, we want to be targeted. The future of medicine is called multiomics. It's precision. It's targeted therapies. It's using genomics, epigenomics, transcriptomics, proteomics, immunomodulomics, microbiomics. It's basically understanding the environment in the cancer, in the body, in the individual, and targeting therapies to specifically target those areas for healing, reprogramming, and targeting the tumor. So in a broad sense, that's what integrative cancer care is. It's integration on multiple levels, but ultimately it's to eliminate the tumor and heal the body at the same time. I just thought that was a good place to start because it's a great question we get all the time. Can dental procedures affect inflammation biomarkers like D-dimer? Yes, there's a lot of things can affect D-dimer. D-dimer is a marker that you see elevated that typically points towards increased risk of blood clots. When you look at advanced cancer, this is something, the D-dimer is almost always elevated. When you look at cancer, cancer is associated with increased risk of blood clots. Inflammation is associated with cancer, and it's associated with increased blood clots. So anything that promotes inflammation has the propensity, the possibility of promoting all three. So inflammation, whether that be from dental procedures, if it triggers inflammatory response, you will see that reflected in D-dimer. You will see that reflected in C-reactive protein, in sedimentation rate. You will see that reflected in a drop in vitamin D, in fact. That can be a sign. So we'll see that even in the treatment at our clinic. The first 2 to 3 weeks of treatment, it tends to be a very direct, aggressive, but natural, holistic, and integrative strategy. And you can see a little jump of inflammation as we destroy the cancer cells. And what that does is that attracts the immune system, and it gets the immune system, the body's defenses, involved in the game. So you can actually see a little surge in inflammation, but then what you should see, for example, this D-dimer, you should see that start to go down. So very normal, you can see a D-dimer go up with initial phases of treatment, but then you'll see that go down aggressively and significantly. Now, we do that in a very controlled manner, integratively, but if you look at it from a conventional perspective, you'll see it go through the roof. So the D-dimer goes up because of inflammation. Okay, cool. So when you look at inflammation, understand that if your D-dimer is elevated, it's because of the inflammation. But the dental procedure itself, which dentistry plays a big role in the immune system, and the gut plays an enormous role, and the mouth is the beginning of it. Any dental procedures done at the time of cancer treatment needs to be protected, needs to have therapy and intervention to protect against that inflammation, propagating other systemic inflammation and triggering and supporting the cancer process. I love this question. I love the questions that y'all have submitted because they're very insightful. They're very detailed, and that's one of the things we've noticed about our patients that we just absolutely love is they are some of the smartest people we know. And I think that intimidates a lot of doctors, but I love it. Yeah, got it. So one question, this question actually came from the UK, looks like Sally. All research says glioblastoma and gliosarcomas are not hereditary. My brother had a gliosarcoma and my half-brother had a glioblastoma. So it's talking about, can these be inherited? Oh, sorry, I got the wrong person attached to that one. But so it's talking about the inheritability of glioblastomas and gliosarcomas. And here's how I would answer that question. Fecal transplants. A friend of mine and colleague of mine has pioneered fecal transplants in a wide variety of treatment of disease. And I was actually just talking to her yesterday regarding some particular cases that she was seeing and some trends that she was seeing. Fecal transplant sounds exactly what it sounds like. It is taking a fecal specimen, sterilizing it, and then providing that bacteria back to another individual to repopulate their gut bacteria. We know that there are several things involved in the gut that contributes to the process of cancer. And one is the depletion of the family of bacteria called bifidobacterium. And when you have this depleted, then if you work to restore that, you can actually help to restore the immune system locally, but also systemically. So this doesn't just apply to colorectal cancer. So she had a family, 3 generations, where the grandmother had renal cell carcinoma, the mother had renal cell carcinoma, and now the daughter in her early 20s had renal cell carcinoma. And so I asked her, well, what's the trend there? She said, I see all of them have a particular strain of E. coli that has been known to be associated with particular types of gastrointestinal diseases. So the point here is when you talk about inheritable diseases, here we're talking about cancer. People think about BRCA1, BRCA2 as it relates to breast cancer or some of the colorectal cancers. Our current understanding and the evidence is showing us that the inheritability of cancer may not necessarily be in a gene that you inherited, that your mother passed to you, that your father passed to you. It could be the gut bacteria that are being passed on from one generation to the next. We also now know through a process called transgenerational inheritance, where the epigenetic or the change in genetic expression of your parents not only impacts them, but it impacts their offspring, and it impacts their grandchildren, their great-grandchildren, their great-grandchildren, and in fact will go out to at least 6 to 7 generations. This was a mouse model where they actually gave one dose of chemo in the peritoneum and noticed that the disease peaked at the 5th to 7th generation, meaning whatever we do, it's not going to just affect our genetic expression, it's going to affect that for generations to come, of which we may never know. So the process of inheritance, we're now starting to understand, is at a much different multiplasticity level than we could have ever imagined, even going back to what gut bacteria are present or not present. Okay. So let's see. Here's another good question. What could cause migraine headaches after high-dose IV vitamin C infusion? Is it neurotoxicity? And how would you prevent this effect? Now, here's a question I have for the audience. How many have received headaches associated with high-dose vitamin C? If you've experienced that, just raise your hand or shout out. Okay, so some have. Okay, so four participants have raised their hand. There's really some significant and very easy explanations to declare that, to explain that out. First, it's not neurotoxic. That's important. We will use high-dose vitamin C at very high dose, very high levels, very frequently here, and have very minimal side effects. I've dosed patients as high as 300 grams before. I've given patients IV vitamin C for 24 hours straight, and it has to be done appropriately. So the first and foremost reason why patients would receive headaches with high-dose vitamin C is dehydrating. So if the patient comes in and is dehydrated, then giving high-dose vitamin C could exacerbate that dehydration, and headaches, the number one cause of headaches is dehydration. So that's one cause. Number two is the speed and how fast the infusion of vitamin C is given. When you look at high-dose vitamin C, it's not just about the dose, it's also about the duration. Because what we need to do is follow what's called basic pharmacokinetic principles. We need the therapy there. We need the therapy where it's supposed to be, the blood into the extracellular tissue to reach the tumor microenvironment, to saturate the tumor and actually saturate the metabolic pathways in both the low oxygen, hypoxic, but also normal oxygen. So here, giving high-dose vitamin C and pushing it too fast, that is probably the second cause of headache that I'll see in patients receiving high-dose vitamin C. And it could be as little as 25 grams. Most people look at 25 grams as high dose, but when you actually look at patients with big tumor burden where it's spread everywhere, 25 grams, you might as well just be spitting in the wind. You're never going to achieve a therapeutic value there. So in that instance, if you push the vitamin C even to 25 grams really fast, you're going to almost induce a headache in everybody. So don't just take the dose, but dose it out over a duration. So typically 25 grams, dose it out over 2 hours or so. Typically that'll alleviate that issue. Another thing that's very helpful if somebody's having headaches is you could actually piggyback some IV fluid with it, and that tends to help with that dehydration perspective as it relates to the headache. Another thing that really helps with the headaches is magnesium. Magnesium helps to augment the vitamin C cancer-killing effect, that is direct cytotoxic effects. Magnesium is a great headache treatment. So giving magnesium in with vitamin C, then infusing it at the appropriate rate, and then making sure the patient is hydrated, this is going to be a triad, a combination that allows you really to prevent and limit headache potential. So very common side effect, great question. And even here on the panel in the chat room, we had 4 people that said they were experiencing that. So how many people have heard of cancer stem cells? Cancer stem cells are the backup that you want no part of. So when we think about our smartphones, right? That's my wife. When you think about smartphones, we need backups there. We need backups there in case something happens, and if we can go back and we can reboot that backup and then restore all of our functions, our apps, so that we can go back to using our phone again. That's a good analogy to what cancer stem cells are. The problem is we can't really test for them. So this question was, how do I know if my body is destroying cancer stem cells? We don't. We don't have a clear evidence-based way of how to assess cancer stem cells. We used to think that cancer stem cells were cells that were cancerous, but they had stem activity, which means they can form new cells. Then there were cancer cells that lacked stem activity. These were kind of the ones that were rapidly growing. We now know that this process is much more fluid. Cancer stem cells can go back and forth. They can adapt to their environment, just as cancer cells can, say we restrict glucose. Everybody says, well, glucose forces cancer to grow. Cancer uses glucose to grow. Well, that's right with a lot of them. But cancer can use protein, it can use amino acids, which are building blocks of protein, it can use fat. Cancer will adapt to its environment. It will adapt to its availability. Cancer reprograms everything around it to allow it to survive. So how do we know that we're destroying cancer stem cells? We can't, but when patients that come to us achieve no evidence of disease, which means both clinically on exam, laboratory-wise, or imaging, all availability of ways to detect and determine that cancer is present, we do not find it. It's called no evidence of disease. That's exactly where you want to be, but now it's the hardest place to be because we have to work on sight unseen, cancer stem cells. Now, the way we work to control cancer stem cells so we can't detect them, it's the immune system. The best answer to cancer is never get it. Obviously, clearly, nobody with cancer says, good, I'm glad we caught it early. Yes, that's correct. But we'd never rather get it. But if cancer occurs, the immune system is the key. There is a process called immunoediting. What this is where the immune system actually keeps the cancer in check. Doesn't necessarily eliminate it. It could be eliminated, equilibrium, and then evasion. Those are the 3 stages of immunoediting. But in this process, what happens is there is achieved an equilibrium where the immune system doesn't eliminate the cancer, but keeps the cancer in a controlled, manageable setting. So the way to not detect cancer stem cells, but actually say, how are we working to control them or destroy them? It is the immune system. So that's why full dose chemo I'm opposed to, because of what it does to the immune system. Yes, it could help achieve, say, 6 months no evidence of disease. That's fantastic. But if it does that at the expense of the immune system, that then allows the cancer to spread, escape, and eliminate that equilibrium or even elimination phase, that is how a short-term treatment can actually lead to the metastatic and thus ultimate end of that individual, because now you've destroyed the immune system, you've spread the cancer everywhere, the immune system can now not do its job. But if we can work within the confines of that immune system and control, then we can nick away at that cancer little by little, and actually take a manageable control situation slowly and deliberately. Of course, we want it as fast as we can, but slowly and deliberately eventually end up in a no evidence of disease situation for decades to come. So great question, very challenging question, because we in medicine and in science today don't have a clinical way to assess that, but we do have a clinical way to attack it. Okay, so here's another really, really good question. So, and I'll go ahead and ask you another question as well. How many people here in the webinar see naturopaths as a part of their cancer care? So if anybody's here watching, just raise your hand. Unfortunately, there's many states here that no naturopaths are allowed to practice, like the state of Tennessee. So this question is, my naturopath just passed away from breast cancer. She did almost everything natural. And allopathic treatments available, yet died. Why? That's a good question. It's a difficult question. That's why I wanted to answer this question, because I thought it's very insightful. It's a good, detailed question, and it's coming from the heart of this individual. I would love to tell you that from a natural, holistic, and integrated perspective, all cancer is treatable, all cancer is curable. Cancer is cancer. We have to be honest with our patients. We have amazing success with the patients that come to us. Most of the patients that come to us, well over 90%, are stage 4 recurrent. They've failed after receiving conventional therapy. So even in those stages, in fact, one of our patients has had 5 different types of cancer. And the 5th kind that he came to us with was stage 4 prostate cancer. He had melanoma, pancreatic, leukemia, and I forget what the other ones were. But and he's now 1.5 years cancer-free. You know, he captains, charter boats. So even in that situation, not 1, 2, 3, 4, but 5 times cancer, and the last time stage 4 prostate, he now has achieved no evidence of disease. So in that situation, we are even able to achieve great success. But yet, some people sometimes succumb to this process called cancer. So then let me get to then the question about, they used almost every natural and allopathic treatment. Well, allopathic treatment is the conventional approach. I've talked just a little bit already about full-dose chemo and the damage that it can do to the immune system, both short-term and long-term. Surgery can propagate the spread. Again, it's not just the what, but the how. The mechanisms are clearly described in the literature. There's immune suppression immediately post-operatively. Even the anesthetics used intraoperatively. And then the post-operative pain management with opiates and Tylenol. We did a webinar last year talking about Tylenol and immunosuppression. Just recorded that podcast last week. Look for that dropping on the Practicing with Dr. Nathan Goodyear podcast, which you can find on drgoodyear.com. So how we manage surgery, and surgery itself can lead to immunosuppression, which can lead to the increase in circulating tumor cells. Get this, even examining a clinical breast exam, they've shown that examining a breast in the office can actually lead to the increase in circulating tumor cells or breast cancer cells. So it doesn't take a lot for that process to move. We have to understand what risk is involved there. And so if we come in with natural or allopathic or conventional therapies, we need to use the science. We need to follow the evidence. So if somebody is going to undergo a conventional cancer treatment, say they're going to undergo surgery, you need to support the immune system preoperatively and postoperatively. You need to really work to minimize the surgical involvement at the time. Chemo. If chemotherapy is deemed to be necessary, how about low-dose metronomic chemo? Not full dose, which does destroy the immune system. Low-dose metronomic chemo is actually immunomodulatory. It stimulates the immune system. So if we're going to use allopathic, we need to make sure it's used in a way that heals, in a way that is scientific, evidence-based, in a way that's going to provide long-term therapy, in a way that can be integrated with natural therapies. A lot of people will go to receive natural therapies, and they will not get therapies that are effective, appropriate, or targeted. Let me give you some examples. People will say, well, I took vitamin C and it didn't work. Well, I have several questions there. Number one, was your blood vitamin C level ever checked? Like, well, I don't know what that means. Well, how do we know your vitamin C was dosed appropriately to be therapeutic in the blood? Because that's what we know is required to achieve the extracellular space, then reaching the tumor microenvironment, to actually then reach the hypoxic areas of the tumor, saturate and destroy it. If we don't know that Reardon said, look, if we achieve 350 to 450 nanograms per deciliter, then we're not optimizing the vitamin C direct cancer-killing effects. Now, vitamin C has many broad anti-cancer effects, but that's just one example. If we're not using the vitamin C and dosing it appropriately, then of course we're not going to see the optimal effects. And what's interesting about that is patients intuitively, they know that. Patients that are sitting, one maybe 5'2", 120 pounds, next to somebody that's 6'6", 360 pounds, they go, well, why are they getting the same dose as me? They're right. I have different cancers. They're double right. What it means is we must dose this therapeutically. How do you treat blood pressure? You start a patient on a blood pressure medicine. Then you try to match that to the type of individual and the type of blood pressure or cause that you think it is. Then what do? You reevaluate. You come back. Let's recheck your blood pressure. Let's adjust the dose accordingly. Same thing with vitamin C. So if we're going to use allopathic therapies, if we're going to use natural therapies, we need to make sure that they're dosed appropriately. Now, the future, as I mentioned, is multi-omics, which means you can provide a therapy that could be conventional, that could be natural, and it may not be the appropriate dose, it may not be the appropriate target. So the perfect example here, again, sticking with the vitamin C theme, is if somebody has a colorectal cancer with a KRAS mutation. This is a mutation the cancer has taken on that upregulates glucose transporters and increases the utilization of the cancer cell and cancer type of sugar to promote its growth. Now, there's a lot of other things, but that's its key component. It's promoting rapid growth by increasing utilization of sugar. That is the exact case of where vitamin C can work and work well. Likewise, there's a targeted med, Lumakras. So if you want to approach it from a conventional standpoint, Lumakras targets KRAS mutation. But guess what? So does vitamin C. So you can see if you approach it then from an integrative perspective, you can actually say, well, let me approach this via a targeted natural way, then follow the blood levels to ensure we're achieving a therapeutic dose, and then providing it with a conventional, if they're seeing a conventional oncologist, or using Lumakras in a very integrative way, and then really make sure, okay, this cancer, the expression of this mutation in the cancer is saying we need to target with these therapeutics. That's what the evidence says. So, so that's how I would answer that question, a very deep-hearted thought question, and my sympathies go out to, all those involved, because I don't like to see anybody succumb to this disease. There's no greater joy to be able to give hugs and high fives to patients that achieve no evidence of disease. But at the end of the day, this is still cancer. It is a beast. And sometimes I go home to my wife and I say, I just hate cancer. I love my patients. I love the people that come to us. There's no more inspiration than seeing people take on this disease called cancer. And our job as physicians, our job here at Brio, is to embrace those patients that are incredibly brave and helping them to achieve success in an evidence-based, natural, holistic, and integrative approach. Okay, here's a great question. Now, this one is from the UK, actually from Scotland. Specific treatments for prostate cancer. Okay, bone. Talking about bone that has cancer that is spread to bone. Now, I want to focus here broadly on this question because I don't want to get in specific details to say, okay, here's what you need to do if you got bone cancer. But let me give you 3 suggestions, as the evidence points to, that really, really helps in bone cancer. Number 1, hyperthermia. Hyperthermia is a therapy to actually mimic a fever. It is a controlled immune response. And again, the best answer to cancer, never get it. Beyond that, the best answer to cancer is the immune system. When you look back in the late 19th century, William Coley's toxin, he was a surgeon that was treating patients with sarcoma. He discovered that by injecting a heat-killed 2 bacteria, he was able to actually induce remission in patients. Now, one patient's remission with stage 4 cancer, melanoma, actually survived 47 years. Now that is a cure. Understand that cure is not a scientifically validated clinical endpoint, but that is a cure. But William Coley and Coley's toxin, when chemotherapy and other therapeutics in a modern conventional way came on board, it lost its appeal because, of course, it was tough. But hyperthermia, brought by Asia, brought by Germany, has allowed us to provide a controlled manner. And when you look at bone metastasis, there's no better treatment than hyperthermia in the treatment of cancer that is spread to bone. So that's number 1. Now, I would say whole body and local, but of course in bone metastasis, especially widespread, that is where whole body is, I believe, the best. But where you can target specifically with local, that's the best. Second therapy is going back to vitamin C and combining it with doxycycline. Doxycycline is an old antibiotic. Here's where we stack kind of an allopathic antibiotic, using it in a repurposed medication. We actually got one question from somebody from London, actually talking about McClellan and her conversations about, and her book about repurposed medications from a metabolic approach to target cancer. And doxycycline is one of those drugs that is an old antibiotic but can be repurposed. It's actually a glycolytic inhibitor. But here, doxycycline, coupling it with vitamin C, it allows, the doxycycline helps to push the vitamin C into the bone better. And so the two together are very effective in basically inhibiting bone growth, that is cancer that has grown into bone. One of the issues that the cancer is doing there is actually promoting typically osteoclasts. When you talk about bone, it's about bone breakdown and bone formation. Bone formation is osteoblast, bone breakdown is osteoclast. And one of the things that you can see there is that osteoclastic activity, bone breakdown, is increased, and that allows cancer to get in there. Doxycycline with vitamin C helps to push in there and really eliminate that process. Very effectively, by the way. And then the third is actually using bisphosphonates. These are, from a conventional standpoint, again, another repurposed medication where we can and do need to use it. This is what you would use for osteoporosis. You can actually use this to inhibit that osteoclastic activity. So that triad right there, hyperthermia, that's holistic. Vitamin C, that's natural. Doxycycline, that's integrative. And then using the bisphosphonate osteoporosis medication for the treatment of bone cancer, that's integrative. These 3 strategies are highly effective in the treatment of bone metastasis. And we've had really, really good results. Been doing this for many years now. And conventional cancer will look at bone metastasis and say, this is uncurable. Again, can't use that word. It's not a clinically validated endpoint. What I would say is appropriate is, can we achieve no evidence of disease? Can we prolong overall survival? We want to be scientific here. This approach, this triad is very successful in stage 4 cancer that is spread to the bone, even in patients where it's recurred multiple times. And I've been using this for many years now and been very successful in a wide variety of cancer types, spreading to bone. Of course, there the most common would be both breast and prostate. Which brings me to a couple questions that I had. One that was actually from Thailand, and the name I can't pronounce, and one that was actually from Canada. Women talking about the different types of breast cancer. Could I help to provide some clarification about them as it relates to treatment strategies? Well, if we look at breast cancer, there's kind of two broad categories. The first category would be a hormonal responsive type of breast cancer, and then the other type would be the non-hormonal responsive. So classically, that is what you might call the triple negative breast cancer. These used to be a very rare form of breast cancer that tended to occur in very young individuals. Surprise, surprise, as we are across the board in a wide variety of cancer types, we are seeing this number skyrocket. Now, triple negative breast cancer means estrogen receptor negative, progesterone receptor negative, and then HER2 negative. Now, I wish they would check androgen receptors, but for whatever reason, the standard of care is not to check androgen receptors in breast cancer. But we know that from research, 80 to 90% of all breast cancers express it. So this means triple negative, that hormones or hormone manipulation will have limited impact on the treatment or slowing of the cancer. Converse, in estrogen positive or progesterone positive receptor, these are hormones, they tend to overall be slower growing, but you can target by targeting the hormone receptors. Now, these tend to be slower growing, and this is where you'll see use of things like anostrozole, exmestane, letrozole. You'll see them like with tamoxifen. So these are the Lupron. These are kind of these classic conventional therapies that would go in to specifically block or shut down hormones, because hormones are really being used by the cancer to grow, though slower than the triple negative. But there you can even use natural, like for example, melatonin is a great aromatase inhibitor. Chrysin, quercetin, these are all natural aromatase inhibitors. Now, they tend to be not as strong, and you have to conversely use them in an integrative with these other conventional, like with anostrozole, and the combination there will work really well together. So the difference between those two is, can you manipulate hormones to slow the cancer growth, such as the hormonal responsive, versus the hormonal non-responsive? You can't really technically use hormones. You have to target them primarily through a different mechanism, because hormones are not the major driving force. But let me present a little bit of a new discovery over the last decade or so about this broad two categories. We now know that with the hormonal responsive, we're primarily talking there about hormone receptors. These are nuclear receptors that are there for the hormone to bind to and trigger then the genetic material to then, precipitate inflammation or precipitate growth signals or these kind of things. We now know that hormones don't need those front door receptors. They can use back doors, side doors. They can come in and stimulate the cancer growth without even using the receptors. That's called non-genomic signaling. So when you look at this from a hormonal responsive perspective category, those receptors are the front door. But understand, hormones don't need that front door. They can use other doors non-genomically, and that applies also to triple negative breast cancer. If a person has high estrogen, they're overweight, they have triple negative breast cancer, I am still going to work. Our team here at Brio is still going to work to manage and control that estrogen, because that could be non-genomically stimulating the cancer growth. This is seen in thyroid in what's called non-thyroidal illness syndrome, where T4 and reverse T3 can actually stimulate the growth of cancer. So this is just a broad categorization of hormonal responsive versus non-hormonal responsive, or what you might call triple negative. Basically, it's can we use hormones versus can we use chemotherapy. That's kind of the conventional paradigm, but actually now new research is suggesting, well, really it's a spectrum, and we have to understand that things are really working fluidly, in a fluid way there. Spit that out, just try to create a new word. But we have to understand this process to then target it. So even in a triple negative, if estrogen's high, somebody's overweight, which that's postmenopausally in a woman, that's where most of that estrogen is going to come from. We're going to still work there even if they may be triple negative. So it's not clear and cut as it used to be, but I wanted to provide that because I think this is a common question that we actually got here from two individuals. Okay. See, any questions coming in here? Here we go. Yeah, I got a question here on the chat. Abigail, I love that. I love that how that's spelled, G-A-E-L. Can you have low-dose estrogen to alleviate menopause symptoms for estrogen-sensitive cancer? Great, timely question there, Abigail. We have to, cancer is complicated enough. I actually had a patient one time when I was talking to him about the biochemistry, the physiology, and we were going down some rabbit holes because of some very good questions. And the husband said, well, wait a second, I thought we needed brevity. I thought we needed short, simple answers. I said, please explain. He said, well, brevity is the soul of wit. And I was like, you're correct, but we're not trying to be witty here. We're trying to be accurate and therapeutic and targeted. So when we look at cancer, we have to understand that it by nature is insanely complex. But by first recognizing that, then we can break through that and say, okay, now let's focus on what we can impact. So when you talk about estrogen, to alleviate alleviate vasomotor symptoms, or here menopausal symptoms, when somebody is receiving hormonal blocking therapy, no, you don't want to use estrogen there, okay? Because if it is hormonal responsive, this is pushing the cancer. Now, there are natural therapies that we can actually use to alleviate those symptoms. One such example is when you look at hot flashes or night sweats. These are categorically called vasomotor symptoms. You can use vitamin E there very successfully. Say a lady is having vaginal dryness and thus intercourse is becoming not tolerable, or say it's contributing to urinary incontinence, which it does. Postmenopausally, the urethra shortens because of the lack of estrogen. You can actually use vaginal vitamin E to actually combat that atrophy, as it's called, of that tissue in the urethra, in the vagina. We don't want to have unforced errors in the complexity of cancer. It's complex enough. So if somebody has breast cancer, it's hormonally responsive, that is, it has estrogen receptor particularly, we don't want to necessarily give estrogen. We don't at all, not necessarily, we don't. We want to alleviate those symptoms in a natural way that won't promote those estrogen receptors. So let me counter that with this. What about progesterone receptors? Now, let me ask this question. I'd like your engagement if you could. The historical context has been that progesterone in breast cancer is a good thing. For those that think yes, raise your hand. For those that think no, don't raise your hand. See what kind of response we get there. Okay, 14 here raise their hand. Historically, that has been correct. But we are now discovering, and there's new evidence coming out. Wiebe has done a lot of work on this. This is a researcher and his team, looking at progesterone receptors, okay? Hormonal receptive. So in the past, it's been, well, progesterone can be used to counter the pro-growth of estrogen. And the thinking there is that, well, during a woman's cycle, estrogen's promoting the growth of the lining of the uterus, right? It's getting everything ready for pregnancy. Then once ovulation occurs, progesterone comes in and stabilizes that process. So that is kind of the thinking that's gone into, well, when progesterone receptors are present, that's a process that's stabilizing it. So that's good, and progesterone tends to be an anti-inflammatory. So that's really good. But we now know that the metabolism of progesterone you can actually give progesterone to women, and the progesterone metabolism pathway itself can promote metabolites that are carcinogenic. So this concept of hormones as it relates to metabolism, as it relates to receptors, is becoming much more interesting, might I say, because it's really starting to really point to the fact that if somebody has hormonal responsive cancer, you need to be very careful, and probably I would advise against giving hormones in that instance, because when a person has cancer, the assumption is, well, when I give the person a hormone or give the person something, that the cancer is going to do everything, the body's going to do everything with it that I want it to. That's kind of textbook philosophy. It's protocolology. So following protocols are thinking textbookology, that textbooks are defining how everything's going. But when cancer is present, when abnormal biochemistry, abnormal physiology are working, it's going to take something that the body needs. So even a woman with ER/PR breast cancer, their body needs estrogen and progesterone. It needs it. So in that instance, though, the cancer is going to do everything wrong with it. And that in turn is part of the problem. This cancer is adulterating and misusing everything which the rest of the body will use for good. So to go back and summarize, no, you shouldn't be using estrogen. There are natural therapies that we can, because we cannot, and you can be very successful there too, by the way. You cannot anticipate that that cancer is going to use that for good. It's going to use that for bad. That's absolutely what we should expect. So this is a great thing about what we do. We are constantly in the science, constantly in the data. It's constantly evolving. It's hard to keep up with. But that's where you develop relationships and collaborate with other doctors, both in Europe, in South America, in Asia, and you work to actually keep all of your colleagues and friends on the cutting edge of helping patients achieve the best therapy, the most safest way, and actually heal. So hormones in cancer, for the most part, is something I work to avoid. Okay, let's see. Oop, a lot of questions coming in here. I've got a lot of questions about diet. So let me, a lot of varieties of diet. So let me, oh, well, here's one right there. Thoughts on melatonin. Cat, great name. Wow, lots of thoughts on melatonin, Cat. Actually wrote a chapter on it in a book that I have not published, but need to. Melatonin is the hormone, right, that helps us sleep. I mean, I take 5 to 10 milligrams of melatonin at night. Why? Because it helps me sleep. Number 2, it's anti-inflammatory. The broad anti-cancer perspectives of melatonin are huge. One of the specific mechanisms is it works within an inflammatory pathway that's called disordered tryptophan metabolism. Melatonin is a hormone made by the pineal gland, but it comes originally from an amino acid called tryptophan. The tryptophan is converted to serotonin. The serotonin is then converted to melatonin. In the presence of inflammation, that process doesn't happen. Tryptophan, it gets diverted away from serotonin and actually goes down an alternate pathway. And this is used by the cancer to disrupt the immune system. And so melatonin can actually be used to counter that. It's called indolamine 2,3 dioxygenase. And melatonin can specifically target that and actually counter that pro-inflammatory, dysfunctional process that cancer uses. Again, cancer doesn't create anything anew. It disrupts and adulterates what's already there. I already mentioned that a lot of estrogen responsive cancers, and understand breast is not the only one, the estrogen comes from male hormones. So a woman's ovaries initially make male hormone and then it gets converted to estrogen. The Leydig cells do that. But in postmenopause, most of that male hormone comes from the adrenal gland. And so even women beyond menopause will make estrogen. And this applies to men as well. So, some of my most estrogenic hormonal patients have been men. They're overweight. That belly, that's an estrogen producing factory. And guess where it comes from? It comes from the male hormones. Well, that enzyme that converts those male hormones to estrogen is aromatase. Anostrozole, letrozole, exmestane, those three medications I mentioned, they're aromatase inhibitors. Guess what melatonin is? It is an aromatase inhibitor. Now, you need to dose it appropriately, and it needs to be high dose, kind of getting back to that, if we're going to use natural, holistic, and integrative, let's dose it right. And so using melatonin there, typically dosing at 150 to 300 milligrams, that's how we would dose that. We follow the levels, yes. Is it well tolerated? Yes. At the higher doses, interestingly enough, it loses its really sleep aid benefit. But when you actually look at the anti-cancer mechanisms of melatonin, it's really broad. It's really broad, and it's an exceptional hormone. And it is one that I would advocate for in the use of hormonal responsive breast cancer. So catching myself misspeak there, I wouldn't use estrogen in a hormonal responsive, but here I would actually use melatonin because it's actually countering the estrogen effects. So this brings me to another great question. We got tons of questions on antiparasitics. Parasites they're parasites, right? We've got tapeworms, we've got hookworms, we've got pinworms, got liver flukes. And understand it's estimated up to 20% of all cancers are caused by infections, caused by infectious disease. And when you look at parasites, they're one of those causes. So a lot of people are advocating and using many different antiparasitics. So this question was talking about Jane McClellan. By the way, I interviewed Jane McClellan in Las Vegas. We have a 3-part podcast that we've just dropped the last, podcast of the 3, where we dived deep into cancers and metabolic disease, as well as repurposed medications, and antiparasitics were one of them. And so that's over at the podcast, Practicing with Dr. Nathan Goodyear. Check that out. Each one's about 45 to 50 minutes, really deep and detailed in terms of the mechanisms of action. But ivermectin and mebendazole. Really interesting. We're actually going to be working with a group to actually collect data and publish on the utilization of this in cancer. Ivermectin, of course, its claim to fame was the last 3 to 4 years with a pandemic, but mebendazole is a lesser well-known, and almost you can't get it in the United States, but they're both antiparasitics. Now, when you look at parasites, what do? Well, they need a host. They grow, they replicate, they spread. Now, take parasites out of that, sounds kind of like cancer. So when you look at parasites, when you look at cancer, there's a lot of similarities. Definitely, liver flukes can cause liver cancer. So definitely there's causation there. But there's a lot of similarities in the pathways that they will use. So it's no surprise that if we come in with like ivermectin, if we come in with mebendazole, and we dose these appropriately, we can then use them to target these activated pathways that both parasites and both cancer will use. So ivermectin does a lot of different things. It's anti-angiogenic, it's immunomodulatory, but one of the things that it does is it blocks what's called the AKT-mTOR pathway. This is a pathway that gets upregulated in cancer that all of our normal tissue and cells use. It promotes growth. mTOR is the pathway, the signal that we use when we work out. We break muscle down to build it back stronger. mTOR is involved there. So ivermectin is inhibiting this AKT, or it's deactivating the AKT-mTOR pathway. And so we don't just go look at these antiparasitics and say, this is really cool, it's an antiparasitic, I hope it works. No, we need to dose it appropriately. Now, this is why we're being actively involved in research at Brio, because I want to not just focus on using natural, holistic, and integrative strategies to heal. We want to add to the science. So the question is, how do you dose with ivermectin? Is it just, 3 milligrams twice a day? Probably not enough. Again, 5'2", 120 pounds, 6'6", 260 pounds. Is the bioavailability, is it going to be delivered and saturatable to the entire tumor and its tumor burden? Probably not there. I tend to dose that based on weight, milligrams per kilogram. Mebendazole, same scenario. Example of what mebendazole does, it inhibits the activation of AKT and ERK in leukemia cells. Okay, that's just one example. So these are ways that you can really pivot, push and pull. Thomas Seyfried, he's a PhD up at Boston College, published many, many articles on cancers and metabolic disease. He's talked about a push-pull theory. And one of the things that you want to do in the treatment of cancer, in the stacking of therapies, is you really want to not get locked into only one therapy. You want to understand that cancer is an adaptable process. It's reprogramming itself and other cells all the time. And we need to do the same. We don't need to react, we need to be proactive in that. Let's see. Let's see, lots of great questions. So I touched on, so for me, this question talking about dog dewormer, you go back to the pandemic, it was ivermectin was maligned as a horse dewormer, right? I mean, that's how it was maligned. Well, it is, but it's FDA approved as a human dewormer too. And the anti-cancer mechanisms of ivermectin have been known for decades. Now, there's a group of us that are going to be working to advance this, so know that we're going to be bringing that. A great oncologist that's doing some work there, and Paul Merrick and others. Let's see. When is total body hyperthermia indicated in cancer treatment? Almost always. Again, for bone metastasis, probably it's the best treatment. Whole body hyperthermia, when you look at it via the German literature, the target there is 40 to 41 degrees Celsius. Heard me right. So there's probably a lot here in the audience that are receiving hyperthermia. How many people in the audience have cancer that have received hyperthermia treatment? Raise your hand if you have. Okay, great. 40 to 41 degrees Celsius is basically 104 to 106 degrees Fahrenheit. That's your core temperature. It's not your skin. Core temperature. Okay? So that has to be monitored via rectal, intrabladder, or via special device allows you to correlate the skin temperature with core temperature. Okay? So if you're not achieving 104 to 106 degrees Fahrenheit for 2 hours, you're not achieving a therapeutic window. When we do whole body hyperthermia here at Brio, it's a 5 to 6 hour process. Now, we use medical cannabis as a sedative, and we use that to sedate people and make them comfortable, because when you look at CBD and THC, all the different phytocannabinoids, CBN, we can actually use these in a way that sedate but don't suppress the immune system. Opiates do suppress the immune system. And so we can use the medical cannabis here to actually sedate as they achieve a therapeutic temperature, core temperature, 104 to 106 degrees Fahrenheit. But then we'll add therapies with that. Vitamin C, curcumin, mistletoe, so that we get that stacking of therapies together. So if ever you get your head in a unit, they're heating you up, that's not hyperthermia. If they're not measuring your core temperature and you're not achieving 104 to 106 degrees Fahrenheit, you're not achieving what research tells us is the therapeutic window for whole body hyperthermia. And there's actually some literature that suggests that suboptimal hyperthermia, whole body that is, can actually promote the cancer growth. So if we're going to use natural, holistic, and integrative therapies, just as we would expect any conventional oncologist to use conventional care, let's follow the evidence. Let's follow the science. We don't have to run from it. In fact, being in the science makes one be more natural and integrative. What I love about Brio is we have an incredible team here. Incredible. 2 medical doctors, 2 naturopathic doctors, a holistic nutritionist, and we get together every Thursday and we go through all of our patients. We talk about the challenges, the successes, and how the different areas of expertise we bring together work together for the complexities of these patients. There's many successes to celebrate, and there's many challenges to try to work through as a group. And that's the challenge, and that's what we do as a team here. So I would not use the quote-unquote dog dewormer, that's febendazole. We would use the human alternative to that. That would be mebendazole. Success with early stage pancreatic cancer? Absolutely, absolutely. Let me tell you what, we're seeing pancreatic cancer, well, we're seeing everything. I mean, I'm going to drop out my southern drawl here. Y'all, cancer's not the same. There was cancer 2018, and there is cancer 2024. They are not the same. And people would go, well, what's the difference? You know. I actually lectured at FLCCC last year, and I'll be lecturing again in a panel form coming up next month. Hats off to Pierre Corey, Paul Merrick, and the board there. Because they stood up when a lot of people were scared to stand up. Spike proteins, okay, no political, whether infection or injection, they promote cancer spread. In the lecture I gave last year, it's very clear. You just have to look at the science. The science is right there. The only way you don't know that is you turn your back. And so we as physicians have to recognize what we're seeing in our patients. Medicine is a science. At its core, it's observation. We're seeing more pancreatic cancer than ever before in younger and younger people. Now, you would say, well, we're seeing more obesity. True, and pancreatic cancer is one that is associated with insulin resistance and obesity. Fair enough. But let me tell you what, we're seeing a lot of pancreatic cancer. And we know that the spike protein affects, it looks like it affects the bifidobacter in the microbiome. And that in turn leads to a lot of gastrointestinal cancers, here including pancreatic. Good success early. Honestly, we've had good success late. Nutrition, ketogenic diet, medical cannabis, vitamin C. These tend to be very, very good, effective therapies in pancreatic cancer because pancreatic cancer tends to overexpress KRAS, so that's why it makes it a great therapy there. So good success with pancreatic cancer early, yes, always, always, always. Late, we've even had good success there. Thoughts on water fasting? Love it. Absolutely love it. It really strengthens and weakens the cancer. Now, it's also very hard on the body. So I would advocate that if you're doing a prolonged water fast, you do so under the guidance of a physician or a team of doctors that are skilled and knowledgeable about that, because that can put strains on your kidney, put strain on your liver. It can be an incredibly aggressive treatment. When people think about tumor lysis syndrome, which is the rapid die-off of cancer cells in the inflammatory response, and that can destroy the kidneys, it's a very dangerous situation. But that can occur from fasting. So fasting is a highly effective therapy. We use it in conjunction with our treatments. Now you have to be careful if somebody has cachexia, that's muscle loss associated with the inflammatory process in cancer. You don't want to do fasting to any significant degree at all in those patients. They need weight, real weight, not unhealthy weight, real weight. So, but if somebody comes in and they don't have cachexia, and we can fast them and use that in conjunction with other therapies, we are going to do that because Cancer did not occur because of one thing, nor can therapy cancer be one thing. It must be stacking. It must be sequencing. It must be combination. That's the way you attack cancer. That's the way you heal, honestly. Yeah, talking about febendazole, the dewormer, I know being used. Again, I do prefer mebendazole because the literature there is clear in humans, and the dosing of it is there, what's called the pharmacokinetics. I know how the body is going, how it's going to be liberated in the body, how it's going to be distributed, how it's going to be absorbed, how it's going to be metabolized, and how it's going to be excreted. So it's called LADME. It's basically pharmacokinetic principles. So if we're going to use these repurposed medications, a great friend of mine, Paul Merrick, wrote a book. It's on Amazon. I encourage you to check it out, talking about repurposed medication, just as Jane McClellan did. But you know, let's use them right. Let's use them right. Let's see. Good question, Kristen. So sauna. Yeah, so depends on why we're using the sauna. If we're using sauna to support detoxification, if we're using sauna to help with pain, it can be an advisable therapy. But if we're using sauna there to try to induce hyperthermia, I would not advocate that. Okay, so in fact, I really don't recommend saunas much at this point for a cancer treatment because of my concern about suboptimal dosing of temperature. Let's see. All kinds of questions here. How do I prevent diarrhea after immunotherapy? Well, understand first, immunotherapy, it's a word that's therapy of the immune system. It's not a classification of drugs. Immunotherapy is anything that affects the immune system. So that's mistletoe, that's fasting, that's ivermectin, vitamin C, low-dose metronomic chemo. I would even say full-dose chemo, which destroys the immune system, that's immunotherapy. It's just bad. So anything that affects the immune system is immunotherapy. So a lot of immunotherapies, their efficacy, their effectiveness is very low. Doing a podcast tomorrow with our holistic nutritionist, Sarah. We're going to talk about exercise and immunotherapy. But one of the things is exercise affects the gut microbiome. And immunotherapy's effectiveness is estimated somewhere between 15 and 40%. Now, effectiveness meaning there's a response. It doesn't mean these patients achieve no evidence of disease. It means there was some effective, positive response. Most of the research says 20% or less. Now, what's interestingly enough, again, check out the podcast, it'll be dropping here soon. Tylenol completely negates any positive impact of immunotherapy. So if you're taking immunotherapy from a conventional standpoint, Keytruda, Opdivo, you take your drug choice, and you're taking Tylenol, very nice, large, retrospective study found that it completely eliminated the effect of immunotherapy against the cancer. So don't take Tylenol if you're receiving immunotherapy. Tylenol is immunosuppressive. In fact, the World Health Organization said, don't take Tylenol if you're being vaccinated. I'm not saying get vaccinated. The point is they said it suppressed the immune system and completely negated the impact of what the vaccine was trying to do to induce the immune system. But talking about diarrhea as it relates to immunotherapy, there's a lot of great strategies there. One is, probiotics. I'm a fan of fecal transplants. The problem there is trying to, coordinate and collaborate with doctors in clinical studies to be able to do that. But probiotics are a mechanism to help with immunotherapy. And again, I touched on this before. Bifidobacter is a bacteria species that tends to be very, very important as a depleted population in cancer promotion. So of course we will support with probiotics and prebiotics, which support the probiotics. But diarrhea, there's actually an over-the-counter kind of natural drink that you can have. It's called Integrate, and it can actually help reduce the diarrhea side effects associated with therapies. So that's something we use here in our product. It is a natural, in our clinic, it is a natural product. but it is a commercial product and it's something that can be used. But yeah, don't use Tylenol, and probiotics of the right variety, right kind, and understand that there's a lot of probiotics out there that aren't very good and effective, but then Integrative for diarrhea is very, very effective. Let's see. Tiffany asking if we use spit that out. Let me get some water here. I really wish this would tell us where y'all are located, because Tiffany, your last name would make me think you're Italian. And then question below is Mahi. That would make me think you're Samoan or kind of Pacific. So Tiffany asked about FLCCC protocol to detox spike protein. We use a variety and variables of that depending on the individuals. Of course, we ask every patient that comes in, have they received vaccinations or have they been infected? Okay, I think this is important to understand. I have seen infections make cancer go sideways in patients that were not vaccinated. Now, we can talk about shedding, which would be on the scope of this. We can talk about contamination, which is what a lot of literature and the concern is about now. But we will use a variety of the detox spike protein protocol there. And we have some addendums to it that we use depending on the individual's labs. There's no way to check that in the US, but depending on labs that we'll see, we may add lumbrokinase in or add some other things in there. But yes, we do use a variety of that. Question is, where is our clinic? We are in the beautiful, sunny, but warm Scottsdale, Arizona, here in the Valley of the Sun, where I think today it was actually kind of chilly. It was about 55, which for us is quite chilly. And you'll see people walking around with parkas like it's 50 below zero. So if you're from where it's cold, then you can get a chuckle out of us who have gotten acclimated to this warm. Yeah, Catherine, thank you for telling that we're here in Scottsdale. Yeah, Paul Merrick, yeah. Love the guy. Brilliant critical care doctor. Get to see him next month. Got the biggest heart of any doctor I've ever met. And he actually published a sepsis protocol on vitamin C back in 2015-16, actually using vitamin C in sepsis. So a great book there. Jane McClellan's book is good. Pierre Corey's book on ivermectin COVID. So really good book there. Ooh, here's a good question. What percentage of chemo is considered low dose? Per the literature, there's no clear definition, but per the literature, it's agreed upon, it's 10 to 30%. 10 to 30% of maximum to tolerated dose chemotherapy. So, and chemotherapy from a conventional standpoint is typically dosed based on weight and cancer type. But here, by using 10 to 30%, you can actually take a immunodestructive process with chemotherapy and it actually becomes immunostimulating. It will actually stimulate dendritic cells, stimulate natural killer cell number and activity. It'll stimulate cytotoxic T lymphocytes. So here's the best of both worlds. It still has cytotoxic, but it broadens its anti-cancer effect. It becomes anti-angiogenic, but it also becomes immunomodulatory, immunoprotective, and immunostimulating. So 10 to 30%, but there's even some literature talking about ultra low dose chemotherapy. That's what it's called, ultra low dose, where they go less than 10%. So, and then what happens with this low dose chemo, you dose it more frequently, okay? So you still have to follow very closely, very intently, because you can take low dose, right, and just take it all the time, and it's still going to have the same effect. But if you use it over a short sequence of time, you can really have a dramatic effect on both preserving the immune system, stimulating the immune system, and actually having an anti-cancer effect. And by the way, we follow natural killer cells. We follow lymphocytes through treatment. And it's always great to go through treatment and be able to show our patients your natural killer cells went up These are immune cells that do exactly what their name implies. They naturally kill cancer cells. So it's cool to be able to show patients that, look, we shrunk your tumor, but look, we stimulated your immune cells. It's awesome. Well, we could go on and on and on and on. What about inflammation with immunotherapy? Not really understanding the question exactly there, Dawn, but inflammation is the bedrock. It's the bed in which cancer sleeps. Can immunotherapy trigger inflammation? Yeah, chemotherapy can trigger it. One of the mechanisms of COVID infection, it can trigger inflammation. Understand, COVID can actually trigger the reactivation of other viruses, Epstein-Barr virus, HPV virus, HIV. So one of the mechanisms is that the spike protein or the infection can reactivate other viruses which are oncogenic. And so all of this can trigger inflammation, which can be it increases inflammation. It's kind of like the water levels that raise all boats, right? The tide that raises all boats. So it's kind of the effect of what COVID does is it raises the tide and it raises all these boats that cancer just takes advantage of. Talking about probiotics for patients not on immunosuppressants. Again, what I like to be and what we like to be here as Brio underneath my leadership is targeted, precise. And so when we use natural therapies, we want to be very detailed and targeted. So probiotics, those can be very helpful. But what we want to do is actually be able to show through testing that bacterial populations have been restored. So if we give somebody a probiotic, say lactobacillus, say bifidobacter, do they need that? What's their gut microbiome? Now we know that the gut microbiome communicates with the tumor microbiome. That's right. The tumor has a microbiome of bacteria that tends to be very specific to cancer type. And these two bacteria populations communicate. So we don't want to guess. We want to evaluate what's the bacterial population, and then what we want to do is target that. And so if somebody needs a fecal transplant, if somebody needs a bifidobacter implant, if somebody can just go with a probiotic, then we'll go with that. But we want to be very detailed. We want to be very specific. We don't want to guess. Natural doesn't require the elimination or ignorance on science. Again, being aware of the science makes one be more natural. We've been hitting this for about an hour and a half. Let's see, is there any specific questions that have come in ahead of time? Let's see any new questions. Okay. Allison, yeah, you bet. Please say something about axillary lymph node dissection and if there are less invasive options when biopsy indicates some metastasis. Yeah. I had a good conversation with somebody I met at a conference here recently, Dr. Simmons, breast surgeon for breast cancer, but now works in the integrative arena. And she'll be on my podcast soon, so check that out. And we were talking about biopsies in cancer. And of course, none of us would like to do them, right? Because there is research, and we talked about a very specific study just published. Actually, let me pull it up real quick. I think I got it here. Hot off the press. Hold on a second. Biopsy. I can spell that right. Okay. This was published December 2023. And it's published in Cell Reports Medicine. Let me make sure that's correct. Yeah, December 19th, 2023. Needle biopsy accelerates pro-metastatic changes and systemic dissemination in breast cancer. Implications for mortality by surgery delay. Now, what they were looking at is they were looking at the cells in the animal model, okay? So this wasn't in humans, it was in animal models. And what they did is they were looking at the cells and the changes that the cells, the cancer cells and the immune and the tumor microenvironment were undergoing. And they were evaluating that and noticed they were the same changes that you would see in cancer microenvironments and in cancer cells that would spread. Particularly, they talked about M2 macrophages, a type of macrophage polarization that promotes cancer growth, immune evasion. And so their conclusion from this was, well, you don't want to wait longer than 43 days after a biopsy to do surgery. That was their conclusion. But they really kind of glossed over the idea that biopsies are promoting the changes in the cell that allow it to evade the immune system. So it's like they completely glossed over that and said, oh, just make sure you get surgery within 43 days. And it kind of gets to the heart of your question there about, Allison, about axillary lymph node dissection in a couple of ways as it relates to biopsies. One day, and I was having this conversation with the physician I mentioned, one day she and I both agreed, we hope that we will not have to have biopsies. We're getting closer. We're getting very, very close. But I don't think we're quite there yet. There's information we can achieve from biopsies that we can't get from circulating tumor cells or some of the great specialty testing that we get out of there like DATAR and others. Guardant Health, Foundation One, all great, Caris, all great tests. But there's still some limited data that we can't get from the blood. So until that time, we do need a biopsy to know what we're dealing with. I mean, what's the tissue type? Is it ER/PR positive? Is it triple negative? Is it from a endometrial carcinoma? Is it clear cell? What are we dealing with? So, but there's ways to protect against that spread. Vitamin C, even the antiparasitics are very beneficial there. But I've never understood axillary lymph node dissection. Here in the Valley, I always tell our patients, I wish we would have met under different circumstances, but we have a great interstate system. We just call it the 101, the 202. Interestingly, we don't call it the 10, but it's called 10. But the 101 is a north loop, and it's 5 lanes, sometimes 6 lanes. So if we follow the axillary lymph node dissection strategy, we would say, okay, there's a backup on the 101. So let's just go blow up a section between exit 12 and exit 13, because that's going to fix the backup. That's what you're seeing in lymph node involvement, okay? You're seeing lymph nodes think of them as like a hub, an exit entry ramp. This is a loose analogy, but it's one that works. They are an entry, an on-ramp, off-ramp to that interstate system. Here, it's the interstate system of the lymphatic. It's one of the mechanisms by which immune cells travel throughout the body. So cancer can migrate through that lymphatic vessel, but also immune cells in there will basically try to stop the growth. So in essence, what's happening in some of this is the immune system actually doing its job. So then let's say you go remove a tumor and you, just as I mentioned with the analogy, you blow up the interstate between exit 12 and exit 13. All right, so you remove the tumor. Yay, no evidence of disease, 6 months, fantastic. Now you've disrupted that immune communication, right? You've gone in there, removed these lymph nodes, lymph node dissection. All right, so then what happens when tumors recur? Well, you've disrupted the interstate. You've disrupted how the immune system can communicate, how it can travel to that area. Now we have a problem. The immune system can't do its job. The immune system can't get there. You're actually starting to see, hats off to conventional medicine, you're starting to see them be less aggressive and more targeted in what they're doing with lymph node dissection. And we need to recognize the lymph node tracts, that's for our immune system. We need to protect it and preserve it as much and wherever we can. The best answer to cancer, again, never get it. The best answer to cancer beyond that's the immune system. So that's my touch on lymph node dissection. I think less is better, if at all. And then, talking about it's the immune system. It's the immune system. And so if we disrupt that, we're disrupting how the immune system can travel. And that is going to lead to a catastrophic process whereby if and when the cancer recurs, the immune system will not be able to do much about it. And that's what you see in the majority of cancer patients. When cancer recurs, it's stage 4, it's spread, and the strategies of conventional have disrupted the ability to target it. It's forced mutations. It's disrupted the travel pathways of the immune system. We need a reimagination of cancer care. Just as cancer can reprogram all the cells around it, and you're seeing this described in the literature, reprogramming. They're saying, this is the word that they're using, the reprogramming of the immune system, the reprogramming of cells in the tumor microenvironment, the fibroblasts, etc., the immune system. Maybe we should turn that on the cancer and reprogram it. Maybe that's what we need to do. So we could sit here all night. I would love to chat with all y'all. I appreciate wonderful questions, fantastic questions. You know, I think it's fantastic. Medicine as a whole, for some reason, looks at patients as not knowledgeable. You are some of the smartest people we know. The patients that come to us are some of the smartest we know. And let me tell you what, I get stumped from time to time by our patients with great, insightful questions. So thank you for being courageous to step out and ask these questions. And thank you for joining us this evening. I hope you have a wonderful Thursday evening, this January 4th. And I hope you have a fantastic weekend. We will talk to you very, very soon. I think the next webinar, is supposed to be in 2 weeks from this time. I will actually, just a little shout out, I will actually be traveling to meet up with a good friend of mine, Nisha Winters, and we are going to if you want to dive deep into integrative cancer, we're going to dive deep. So that will be a podcast that we will be doing, and might even do a live webinar with a Q&A with her, trying to work on that as well. So always pushing out the podcast. Check it out over at practicingwithdrnathangoodyear.com, which is on drgoodyear.com. Of course, you want to find out about the amazing work we do here at Brio-Medical.com, and wherever you surf the internet, the web, social media, we're there. Have a great evening and have a fantastic weekend.